I'm going to talk about two very new advances in treatment of bone diseases that we see in children. One is somewhat rare, one is rather common. I want to start by pointing out that this is not Athens, Greece. This is Nashville, Tennessee, where Vanderbilt University is. That's the world's only full-scale replica of the Parthenon. It's pretty much intact. We don't have to fight with the British Museum to get the Elgin marbles back. That's Vanderbilt University over there and our children's hospital, but I won't waste time on that. I have rather ambitious goals. This one, okay. My objectives today are to review two disorders who unfortunately have very similar names, but are both related to they have a central kind of role of alkaline phosphatase. One of them is hypophosphatasia, a mutation in the alkaline phosphatase gene. The other one is X-linked. See, I'm not doing a very good Lady Gaga here. Are we good there? Okay, thank you. And the other one is X-linked hypophosphatemic rickets. I want to discuss a differential diagnosis of both of these conditions, and in particular focus on exciting new treatments for both of these disorders. And I want to do this all in 20 minutes. So, we're not moving very... Yeah, it's the last one. Oh, it just happened. So, we're going to talk about rickets. Rickets is part of the spectrum of abnormal mineral deposits in bones. So there's two different nomenclatures that we use. Rickets is something that only happens at the growth plate of a growing bone. You have to have a growing bone. You have to have open growth plates in order to develop rickets. When you don't have good mineralization there, that's what evolves as rickets. In an already mature bone, in its deposition of calcium and phosphorus into the matrix of the bone, we call that osteomalacia. So children can have osteomalacia, they can have rickets. Adults, once they've closed their growth plates, do not have rickets. There are two major issues that have to deal with the development of rickets or osteomalacia. One, it's a problem of getting calcium and phosphorus into the matrix to develop a skeleton. So we have calcipenic rickets, where calcium is the limiting factor. By far, the commonest disorder that leads to that is vitamin D deficiency and nutritional forms of rickets. I know from past experience here, and having talked about this with you, you guys know this very well. And just because there's a lot of sunshine, not today, but in Jordan, it doesn't mean that there's not a lot of nutritional rickets. What we're going to talk about today, though, is another form of rickets that has nothing to do with vitamin D. And that has to do more with the disorders of phosphopenic rickets. Calcium's not the rate-limiting step. It's not vitamin D. It's inadequate phosphorus. Now, how do you get inadequate phosphorus? You know that food is just totally laden with phosphorus. Unless you are on total parenteral nutrition and not getting appropriate intravenous phosphorus, it's very hard to become nutritionally phosphorus depleted. But there are a number of conditions that are outlined here, mostly disorders of the kidney that result in loss of phosphorus into the urine. Normally, we filter phosphorus and then reabsorb it. So there's this cycle of reabsorption of phosphorus to maintain normal levels in the blood, to maintain normal levels for ossification and other processes. We're going to focus today on X-linked hypophosphatemic rickets, but it's one of a number of disorders, and the treatment I'm going to talk to you about is a drug that actually gets at the mechanism of hypophosphatemic rickets that was not available until just like a year ago in the US. But X-linked hypophosphatemic rickets is part of a series of disorders in the kidney that involve high levels of a protein called FGF23. I'm not going to go into the physiology of this, but FGF23 is an important part of the normal physiology of reabsorbing calcium. FGF23 blocks reabsorbing phosphorus. When you filter phosphorus, you reabsorb it, except in the presence of FGF23, which prevents the reabsorption. So if you have a disorder, let's say a tumor, there's certain tumors that make high levels of FGF23, you dump phosphorus into your urine. You have high urine phosphorus, you have low serum phosphorus, you have osteomalacia, you have rickets, you have seizures, you have all sorts of problems. And I won't go into these other rare conditions. This is something endocrinologists love, McCune-Albright syndrome. There's a whole host of conditions that if we can learn how to harness FGF23, we can make better. But again, I'm going to focus on the X-linked hypophosphatemic rickets. I won't even go into the latter one. So this is a disorder, as I mentioned, of renal phosphorus loss. It's not rare. It's 1 in 20,000 live births. There are many cases of this in Jordan. Its genetics are quite clear now. It's X-linked. That doesn't mean girls and women cannot be affected by it, but primarily it affects males. It's on the X chromosome. In particular, the mutation is one in a protein called PHEX. It's a endopeptidase. It basically cleaves other proteins, and we really don't know how exactly, but when you have a mutation in the PHEX gene, you have high levels of FGF23. You dump phosphorus and you develop osteomalacia and rickets. So the key thing is we don't really have we have a very good treatment now for this disease, but it does not target the primary genetic mutation. It's a downstream event of this. But the manifestations are hypophosphatemia, hyperparathyroidism, rickets, poor growth, nephrocalcinosis, and in severe forms, seizures. So what have we had to treat it up until now? One thing I didn't mention, actually, let me go back one slide. The old name for this used to be called phosphate diabetes. It's really kind of interesting. It's kind of like glucose loss in the urine. It's kind of the phosphorus equivalent of diabetes, except that in the blood, phosphorus levels go low while you're dumping lots of phosphorus in the urine. So the treatment up until now, has been treating children with large doses of various forms of phosphorus. And I'll tell you, that's the flaw in what we've had to treat this disease until now. It's horrible to give people phosphorus. They don't want to take it. It upsets your stomach. You have to take it multiple times a day. It's been formulated in organic formulations. There used to be a thing called Phoslamar that you could take maybe twice a day. Nobody liked to take it. Nobody took it. And the outcomes from this disease were terrible. It usually wasn't fatal, but people with X-linked hypophosphatemic rickets were always short. They were bowed. They had fragile, broken bones. And then finally, in 2018, in the US, and I think it's also in the EU at the same time, has come a treatment for this. And this is targeted right here. That's an antibody. It's a monoclonal antibody against FGF23. Now what we see there, that's an FGF23. That is a cell, let's say a renal tubular cell, that has receptors for FGF23. But what happens is the FGF23 is bound up by the antibodies. You can reduce the levels. It can't get to the receptors, and you can reverse some of the changes in various diseases where there's too much FGF23. So this drug, I'll show you in a minute, burosumab, inhibits this. You give it every 2 weeks subcutaneously. It's like you're not eating phosphorus like 6 times a day. And the outcomes are remarkably good. So let me show you a couple of outcomes. Here's treatment with burosumab. I'm synthesizing a lot of data very quickly because I want to cover one other thing and be done on time. Here's placebo, these are kids treated with phosphorus and high doses of vitamin D. That's kind of the placebo group here. This is burosumab, serum phosphorus goes up. Reabsorption of phosphorus goes up. Here we see alkaline phosphatase activity goes down in the treatment. In the placebo, it stays high because you have excessive bone turnover. This is rickets. This is a scoring system of rickets. I won't go into this. It's like a 1 to 3, 0, 1, 2, and 3, but basically the total rickets severity score goes down on treatment. In the toddler form, juvenile form, this is with the burosumab. It's dramatic, and let me show you some pictures of this. This is 40 weeks of treatment. You can tell that's rickets, a wide, frayed, kind of rat-eaten metaphysis here, cleared up. Same thing in the wrists, the hands here. You saw that in the scoring system we used before. Here it is in the hands. You know what? I missed one picture. Let me show you exactly what this drug is. I think somehow we missed this. I think I left it out, so I won't go there. Just a little bit more about the monoclonal antibody, but we'll go without it. It does not cause hyperphosphatemia, which is a risk when you're giving someone excessive amounts of phosphate. There are no clinically meaningful changes in hyperparathyroidism. It does not result in even higher PTH levels, serum or urine calcium. There are no hematology effects. The major side effect is about 50% of children will have a mild skin local reaction. It's given subcutaneously. But finally, we have a disease-specific treatment for X-linked hypophosphatemia. It's expensive, as everything is these days. New drugs don't come cheap. About $100,000 a year for toddlers and preschoolers, $400,000 a year for older adolescents. I can only hope this is going to come down and somebody's going to figure out a way to do this cheaper and not feel they have to extort money from us. It's the final form of rickets to have a disease-specific treatment. Vitamin D, remember, it has nothing to do with this one. It can lead to significant improvements in mineralization, growth, motor function, fracture healing, pain, and stiffness. I didn't show you the data. It's wonderful. And continued follow-up needs to occur because this drug has not been out there for decades, but we think it's going to be really a quite good one. All right, I'm going to finish by switching gears. Another disorder of low alkaline phosphatase. So I'm going to tell you about a child, just a very brief introduction, a 20-month-old child who starts losing teeth. He's lost 6 incisors, 4 loose teeth, painless, no gum disease, and going the wrong way. I'm going backwards. Down. There we go. Sorry. No blue screens yet, though. This is good. Otherwise healthy kid. No history of fractures. And physical exam confirmed that he lost teeth. He has abnormal feeling skull. We'll come back to that in just 1 second. Otherwise normal, other than at 20 months, he's unable to walk. All right, here are the lab results. And you can see here what we've got is a normal calcium and a normal phosphorus. But one thing you might have missed, and I'll tell you for decades, I never paid attention to this. Look at the alkaline phosphatase. It's low. We're all, as endocrinologists, I think as pediatricians, we're used to looking for disorders where alkaline phosphatase is high, right? Because that's rickets, that's all the bone diseases we know. This is a disease of poor mineralization because you have low alkaline phosphatase. The normal range, remember, often what your lab will report is a normal range for adults. You have to be thinking as pediatricians, though. Growing kids have a higher range for alk phos than adults do. Now, one other thing that was measured in this child is pyridoxal phosphate. I'll come back to that. It's a phosphorylated form of vitamin B6. It's exceedingly high. It's 1,824 nanomolar as opposed to a normal that goes up somewhere around 100. Okay, so in this disorder, the only disorder of bone metabolism that has a low alkaline phosphatase, ALP here, is hypophosphatasia. D-resistant rickets, X-linked hypophosphatemic rickets that we just talked about tend to have very elevated or elevated alkaline phosphatase, osteogenesis imperfecta, which is a problem of the collagen matrix of bone, does not have disorders there. So what is HPP? Hypophosphatasia is a mutation, an inactivating mutation in the alkaline phosphatase gene. You have very low alkaline phosphatase activity. Here's what the common thing that a phosphatase does. That's pyrophosphate. Remember, 2 phosphates stuck together. That's phosphate. That's alkaline phosphatase there. When you have a mutation, you block that step. So you have decreased activity. It's a little less common, about 1 in 100,000 live births. There's a variety of different mutations. So it's recessive. It's autosomal recessive. That's important because in communities here, as in the US, we have some communities of consanguinity. You're going to see more of this in that situation. Now, let me just show you a very important point about this. That's alkaline phosphatase. This is an osteoblast. This is where bone is made. That's pyrophosphate. It's generated from ATP to AMP. You get pyrophosphate. You want to get that phosphorus into the extracellular bone matrix. So there's a channel here that exports pyrophosphate to the extracellular space. Alkaline phosphatase, which is sitting on the outside of the osteoblast, cleaves off one of those phosphorus groups, so you get phosphate, and then you get normal bone mineralization. If you can't cleave it to phosphate, then you have high levels of pyrophosphate. That inhibits bone production. So then you have poor mineralization. You get either rickets or osteopenia, and that's the mechanism of what goes on here. Now, let me just point out one other thing here. This thing in the central nervous system, we'll come to that in a second. There are other phosphated proteins that are affected by alkaline phosphatase. And one of the consequences of hypophosphatasia is seizures and neurologic dysfunction because of poor CNS, intraneuronal levels of pyridoxine, the vitamin B6. That's because of an alkaline phosphatase problem. I'll show you in a minute. So you have increased pyridoxal phosphate, which leads to high levels in the blood, low levels in the neurons, and neurologic sequelae. We've already talked about this whole spectrum of disorders that go on in the skeleton. And then finally, there's another chemical that we can measure in the blood or urine called phosphoethanolamine. That's, again, another substrate for alkaline phosphatase. When you have high phosphoethanolamine, let's say, in the urine, it means your alkaline phosphatase is low. But usually a serum alkaline phosphatase will tell you the same thing. Let me just show you a couple of pictures, and then I'll end. These are bones of normal and hypophosphatasia. You can see the rachitic and poorly mineralized bones. One of the hallmarks of this disorder is that you lose bone matrix. Here's a child. Look at how sparse those ribs are. Here's the skull. Those are craniotabes. You get a premature fusion of the sutures. Here's what happens in the brain. You need to get pyridoxine into the neurons. It's got a phosphorus on it. You need to cleave that phosphorus off in order for the vitamin B6 to get into the neurons. And then it gets phosphorylated again. But if you can't cleave it off here, you cannot get normal B6 into neurons. That's why you get it's very important for a variety of neurotransmitters. There's a seizure disorder that goes with this. That's what happens in that condition. This disorder is often misdiagnosed as nutritional rickets, as dental disease, osteoarthritis. I'm going to show you a couple more pictures and then we'll end. There's a spectrum of disorders. When I first saw this disease, when I first became involved with this was about 25 years ago, it was uniformly fatal because what we see is the perinatal and infantile form the most. When it presents at this age, there used to be no hope for these children. There's an older childhood form that's a little more sparing. There's a primarily dental form called odontohypophosphatasia, and there's an adult form. And the key point is you get failure to thrive. The first child I knew who died at like 24 months of age, a beautiful little baby boy, failure to thrive, poor feeding, craniosynostosis, osteopenia, and what ends up happening is they lose mineral from their bone. Any mineral that they accrued in utero disappears. This is a child at 32 months. See how much calcium you can find there. Here's 7 weeks, 32 months. Same thing. They start losing bone mineral. Look at this. This is a birth, 5 months, 32 months. Where's the bone? It just disappears. And what happens in the thorax is they don't breathe. And they typically died in the pre-treatment days of respiratory failure. You ventilated them, but they had fractures. They did very poorly. And so the treatment was always various treatments to try and prevent them from getting hypercalcemia because they were remodeling bone, and ventilatory support. Here's what's new in this disorder. People recognized it was a problem with alkaline phosphatase, so they tried infusing alkaline phosphatase into patients with this, and it didn't help. But the problem there was alkaline phosphatase, remember, sits on the membrane. It has to be sitting on the membrane of the cell where it works. It has to be sitting on an osteoblast in order to work properly. So this drug, burosumab, was developed. That's alkaline phosphatase. That's the enzyme. Here it's linked to a deca-aspartate, a bunch of aspartate molecules that targets it to bone cells. So in other words, it deposits a new functional form of alkaline phosphatase right to where it's supposed to go. And here's what's happened to mortality and treatment with this disorder. Historical data here, 80% were dead by 2 years. Treated, what is it, about 10% had mortality. Here's what happens to bone, 35 months of treatment. See, there's bones coming back in the chest. You can see bones again. So hypophosphatasia is a phenotypically diverse disease. It can prevent at various stages of the life cycle. It affects multiple systems, not just bone, but pay attention to the alkaline phosphatase. Don't blow off a low alkaline phosphatase is like, well, I don't know what that is. You think about hypophosphatasia. It's not rare. It's also $286,000 for up to 9 kilos. This is outrageously expensive. $500,000 a year for between 10 and 14 kilos. And for the adult form, it can be $2.5 million a year. Obviously, in my country, the insurance companies are not jumping at paying for this. In the children, they will, but the adult form is still is still, the adults fight for this. I'll stop here. Thank you.